Good morning, good afternoon. I want to, on behalf of IFSO Latin American chapter, to welcome everyone. First of all, I want to say thanks to Mariano Palermo for organizing this important webinar and, of course, for choosing this interesting topic. And I want to thank to the moderators, the panelists, and, of course, our two speakers this morning, this afternoon. I'm going to invite you. I want to remember you that we have our IFSO Latin American chapter Congress in Cartagena in a couple of weeks. We are waiting for all of you, and I let the microphone with Mariano to begin this webinar. Thank you.
Thank you, Sergio. Good morning and good afternoon, everyone all over the world. It's an honor for me to co-chair this session with Professor Nathan Sundell and Edgardo Serra, and our panelists, Ana Carrasquilla from Costa Rica, Enrique Arias from El Salvador, Julián Varas and Camilo Bosa from Chile. And we have two great conferences today. We are going to start with Professor Marcelo Loureiro from Curitiba, Brazil. He's going to talk about the future of telesurgery, and after that, Michel Gagnier is going to talk about the magnetic anastomosis. So, Seba, we can start with the video of Professor Loureiro.
Good morning, everybody. Thank you, Dr. Palermo, for inviting me. It's a pleasure to participate in this meeting. And we are going to talk a little bit about our experience with the telesurgery here in Brazil. From 2001, the world has experienced the beginning of telesurgery with Dr. Gagnier and Dr. Marisco, with what was known as the Lindenberg operation. That was a real breakthrough on surgical technology, showing the world what could come next. At more or less the same moment, we were also experiencing the first bariatric robotics. But for both bariatric robotics and telesurgery, we would still need 2 decades for them to further develop to start reaching the mainstream status. Telesurgery means a surgeon operating a patient far away. That far away could be other hospital, other city, other country, or other continent even, like Dr. Gagnier has done with Dr. Marisco. So this is about the concept. Telesurgery means operating in a distance, just like the name says. We need robotics to do that. We need this technology of submillimeter precision, and we need telecommunication technology to make it feasible. Latency is one of the major issues. Today, it should not be higher than 300 milliseconds. This is critical. And meaning that the delay between what the surgeon does in the console and the robot arm movement on the other end of the circuit must be within that range for the cognitive comfort zone. Today, the fiber optic cables are still the best way in terms of communication, telecommunication, to allow the telesurgery to be done. But in a few years, probably we're going to use much more the mobile network, like the 6G or even the 10G that is being testing in China nowadays. So 10G means 10 gigabytes per second. The robotic platforms today that are available in the market and that are able to do telesurgery are especially these 3 platforms. There's another one. It's not in Brazil nowadays, but it will come. There is a Japanese one, but the most part of this technology comes from China. It seems so far that Edge Medical has, the company from Shenzhen, has more experience, and because they're a company fully dedicated to medical robotic development. But we also have the Microport is from Shanghai, and the giant in the west, in the east, and also the platform from India, SSI Mantra. So those are today the most important platforms capable of doing this kind of technology, applying this kind of technology. The first bariatric telesurgery was performed last year in July by Dr. Mohit Pandari. He published a series of 10 patients operated in a distance of 900 kilometers with the Mantra robot, with the Indian robot. He has performed the one anastomosis gastric bypass for those 10 patients. And the results, they are pretty much compatible with the robotic one anastomosis gastric bypass. Should not be different because you're talking about the basics of the same technology. So that was the expected. And talking about literature series of publishing this first cases, this is what we are seeing today. A little bit what we have seen in the past between laparoscopic surgery and open surgery, then robotic and laparoscopy. Now we are comparing telesurgery with robotic surgery, but for sure, if the difference between robotics and laparoscopy is small, of course, telesurgery, if you don't have too much delay, you should have more or less the same results, especially in terms of quality, in terms of complications, etc. If you're talking about the same surgeon or the same level of qualification of surgeons. This is a Scholar. This is our training center in Curitiba. Curitiba is a city in the south of Brazil, and we have chosen to buy this technology and to bring it to Scholar because I personally believe the surgical training centers, they has a central role to spread any kind of technology, any kind of surgical technology. So I think that this is what we believe is the main role of surgical training centers. Also because telesurgery has interesting potential to finally democratize and excellence in surgery. And because it's an amazing surgical tool, surgical educational tool, and also because at this moment we could help to lead this process in the continent. So I think that especially in the beginning of the spread of this new technology, it's really interesting to keep it, to have it in training centers like we do in the Scholar. So our project began with the first telesurgery in South America. We have performed a swine operation between Scholar and Cascavel. Cascavel is a city 500 kilometers away from Curitiba. And during the surgery, of course, all the parameters were registered, and then we published our first case. So we have performed a telesurgical robotic cholecystectomy, and all the parameters were even better than we expected. We had a latency, a delay of no more than 30 to 40 milliseconds. This is nothing, almost zero, in a 500 kilometer distance. And during 1 hour of surgery, almost zero connection instability. Then we have moved for the second stage, the second step of this project. We have used the same cable connection. We have installed a cable, or we were using a dedicated fiber optic to do this, to perform the first surgery. And once it was installed, we took advantage of this installation to promote a telesurgical education program. And this was done, this project was, they had the intention to train all the staff, the young surgeons from the University of Cascavel, of the city, and we are performing routinely in a routine basis around 10 surgeries per session. That means once a week we are training all those people with lots of surgeries through the telesurgery protocol. One proctor in Curitiba can train dozens of those guys, and that is speeding up the skills of their skills dramatically. This is nice, and in my opinion, this is a nice and clear demonstration of the rational use of resources. This project has caught the attention of the state government and the federal government of our country. This is just one of the sessions. We really can train a lot of people, and it's feasible, and we can see how they can advance faster in doing more and more procedures. Of course, all those guys, they have passed through the simulation process that is the standard, I think, all over the world nowadays to become a robotic surgeon. But once they have overcome this learning curve in simulation, they go to the robot and start doing procedures in animals. Then we move for the third step. The third step was the first interstate Brazilian telesurgery. And Brazil is a continental country, so we need to test it at Brazilian conditions. We need to test this technology in Brazilian conditions. But this time, with a normal, not dedicated cable, we made it simpler and cheaper, and at a bigger distance. We've connected Curitiba to João Pessoa, 3.3 kilometers, 1,000 kilometers apart. Again, in a swine model, the surgery was also uneventful and with a delay below 50 milliseconds. So that was the third part of this process, and we were able to connect Curitiba to João Pessoa, big distance, very low cost internet connection, and we kept the delay below 50. Then we moved for the fourth step. We were ready to do it, and that was a project that took me at least 2 years of preparation to perform the longest distance between a patient and surgeon so far. This project involved more than 150 people from 3 different countries, and we were able to deliver a surgery of inguinal hernia with the 200 milliseconds, that in a distance of more than 12,000 kilometers away, of what we call the geodesic distance, between the distance in the map between 2 points, and a cable distance of 15,000 kilometers. It was even recognized by the Guinness Book as the longest surgery so far. Besides that, at the same moment, we were able to deliver 2 other milestones. That was the first human telesurgery in Latin America, and the first round trip. Means one surgeon in Brazil was operated by one patient in Brazil was operated by the surgeon in Kuwait, and vice versa. One patient in Kuwait was operated by a surgeon in Brazil. That was strongly reported in the media and in all over the country. More than 200 times it appears in the media, and the most important media in Brazil. And for Kuwait, it was a kind of national conquest for them. So this Guinness certificate and everything. It was really, really very. We have spent a very good time. We did a difficult project, and we were able to achieve that. After all those cases, all those steps, our state government decided to get inside of the boat and help us to establish this first telesurgical hub of our country, connecting 5 university hospitals in the state of Paraná. That has, in my opinion, the potential to accelerate robotic surgery proficiency among local surgeons, just like we are doing with the young surgeons in the city of Cascavel, and also to better understand and establish models, some new business models for this new technology. So the state of Paraná understood that this can be a very interesting tool for them to promote this science, technology, and medicine, medical care in the state, and to be like an advertisement of the state for the entire country. I think they are right. They're very correct about this understanding, and of course, we'll try our best to make this happen. Simultaneously, and this is also a dream, we are negotiating with the federal government of the country to start a project to do the same thing in the entire country, because Brazil has the need for this kind of solution. This is a big country with and the standards of care are very different between the regions of Brazil, between the cities. So we have very poor cities. We have places where the correct surgical care does not get even close. So with this kind of uh, technology, maybe we can correct a little bit this kind of differences in the country, at least in surgical care. In Brazil, there is a particularity during the pandemic, the because of the need for telemedicine. Brazil has installed 40,000 kilometers of a very high quality fiber optic cables, and those are available for this kind of technology. We have used this, a part of this, during our surgery to our connection to João Pessoa, and they work pretty well. So the basic infrastructure is already there. Of course, telesurgery is not only for bariatrics, it's for all surgical specialties that can be managed by robotic technology. What makes this technology very interesting, because it can uh, also be used by lots of different surgical specialties. The potential is open, potential for savings of unnecessary displacement, from savings of unnecessary displacement to exponential widespread surgical expertise. There is a potential for a lot of potential for brand new business models, even for hospitals, for insurances, for surgeons. So it can be a different way, a new way of course, of making money too. And for sure, for the patient, we we are thinking about only good points, good advantages, especially keeping it safe. If we keep it safe, eliminate the geographic barrier is a dream, but now finally we have the means to start, maybe to start equalizing access to top quality surgery for those who have never had it, not even in their dreams. So this is the beauty of telesurgery, in my opinion. It can really get the surgeon, the expert surgeon, to the patient that most need him. The problem of this kind of technology, of course, is the price. So we're talking about an important capex. Means that the initial investment is very high, but there are things that is happening nowadays that can make it a little bit easier, especially the concurrence. We are talking about a lot of platforms that will get into the market and the prices will go down, just like everything When China gets into the market, every price goes down. So this is already happening now in Brazil, and I think once we have maybe a little bit lower capex, we'll talk about the potential of savings, because the the best the technology is, and the lower the prices of using it, of course, we will start making some provisions of how much of this money of these placements we are going to save. Telesurgery and teleproctoring can even change the speed of surgical innovation. And in my opinion, also the innovative surgeons will be able to spread their ideas faster and with less need for travel abroad. So once you have a new technology, and once it's feasible to do it by telesurgery, maybe you're not going to do it the first surgery by telesurgery, but the next the other surgeries for the same surgeon that is learning, you can probably use this kind of technology. So I think this potential of faster widespread of technology is very interesting too. It's something new, and a lot of work of regulatory process must be done. It will take time for all the stakeholders to accept and get used to that. Policies are always a threat to development of any technology, but it's necessary. You have to understand it, and we have to create the right protocols to avoid any risk. If everything goes well, we can dream of those changes to be happening in the next few years, and this is the potential of this new technology. Independently of what kind of technology will become mainstream, I have no doubts that the future of surgery will be connected, precise, and maybe even with fewer borders. I hope we'll be alive to see that happening. Thank you very much. Thank you again for Dr. Palermo for inviting me. I'll be available for any questions that you want to ask me.
Thank you, Dr. Loureiro. Now we have open to the questions and comments. If somebody from the audience want to make a question, please raise your hand. Welcome, Michelle. Hello, how are you? So, Nathan, any comment?
I want to ask Marcelo something. Marcelo, how do you handle the legal side and the privileges across the countries, even across the cities, across the hospital? Do you need to get some legal advice from every country? So how do you handle that? Yeah.
You want me to continue to speak in English, or do you prefer to
No, this
English.
in Spanish, as you want?
English.
Okay. So to perform those surgeries, of course, it's a long way, because nowadays we don't have all the regulatory aspect of this established. So we have to go for our councils, the federal council, the local council. Regarding the international transatlantic surgery that we have done with Kuwait, of course, we had to get all the authorization from the legal part of their country, our country. So that's why it was a long way. That's why it was so difficult, because I don't know. I have signed at least 30 documents to make it happen. So of course, there must be someone that is responsible for all these things. That's why it was so difficult in the beginning. I think that with time, more cases, and more widespread technology, that will be naturally easier. But today is still kind of a little bit complicated. But it's okay. It works. I have nothing was so difficult to overcome.
Michelle, you were the first to do this 25 years ago.
Yeah.
What is the difference 25 years ago, now the delay? What is your opinion about telesurgery in 2026?
Yeah. Well, I know he was telling below 300 milliseconds. We had 365 milliseconds, so it was at the limit of the acceptable. I remember when we practiced with pigs, it was at a higher delay level, and it was terrible. But talking about the regulatory issues, we had to give Jacques Maresco privileges in surgery from the Mount Sinai in order for him to be able to do surgery from New York State. So he was considered as a surgeon performing procedure in New York. There was a question about malpractice insurance if something had happened, even though his patient was in France. We had obtained permission and all the paperwork and everything as if he was a surgeon for a single procedure done in New York. This will cause a lot of problem when it's going to be in between countries. You know, in my own country, there are 10 provinces, and I have a license in Quebec, and I cannot practice in Ontario next door. So, you know, how is that going to be handled? The malpractice insurance, if there's a complication, who sues? If there's a problem with the connection, is it going to be the telephone company? Is it going to be the robotic company? Is it going to be, you know, 25 years ago, we asked ourselves all these questions, and they're coming back again as I see. The other thing is, the end, when I thought about the case we did, I said, well, if we get in artificial intelligence and the robotic system are intelligent enough, are we really going to need the distance? Because you're going to have the system at the location where you're going to do the surgery, and probably they're going to be able to do the surgery without us being present remotely. So I told myself that answer 25 years ago. So I would be interested what Marcelo thinks about this concept.
Well, first of all, this is wonderful to have the guy that has begun this before and had raised those questions 25 years ago. So I think we are living maybe in a different moment, and I want to believe that. I want to believe that. That we can be able to overcome these policies, because they're very straight. They're difficult. They are difficult to overcome. We need some kind of passport, you know, Dr. Guinea, that can bring us more together. And I know this is a kind of John Lennon statement, but we need something that makes us more flexible, you know. I believe this technology, if I look at the optimistic part, this has the potential to bring the patient closer to the specialist. But we have to put this in mind to try again to overcome these barriers. Otherwise, the policy will win again. So we have a wonderful technology. In a country like Brazil, like I said in the presentation, it's a continental country, just like you have in Canada. But different from Canada, we have big differences in terms of quality of care. So in a country like ours, it seems it can be a good way to equalizing the quality of care of medicine. So that's why the government is supporting us right now. In the beginning, I was completely alone, but now they look at it and they realize that they can even update the policies to make this happen in the country. Talking about the transnational surgery, this will be more difficult for sure.
Camilo and then Ana. Camilo.
Marcelo, very interesting. What has been the experience Brazil with telementoring? Because one previous step would say one would have thought that telementoring could be like the first step, and then start doing more things. Because for me, transatlantic surgery, and I found very amazing what Michelle did 25 years ago, but it looks like something similar to arriving to the moon. We still don't know what was been the usefulness really of being in the moon, and now 25 years later, we're still putting the space for robotic surgery, and now telementoring, and then telesurgery. What do you think are going to be now the telementoring, and what are going to be the first benefits you think you're going to see when you start really implementing this more widely?
Yeah, first of all, I think, just a second. Sorry. First of all, you're right. If we look at this kind of thing and see how difficult it is the comparison is going to the moon. But nowadays we are understanding why we should go back to the moon. It has a lot of advantages for the future of of humanity, of a human being. So that's why a lot of different countries, they are expecting to launch rockets and to start colonizing the moon. Of course, this is a long-term project, but now we understand that it's important. So if we compare it of what Michel Gagné and Jacques Merisco has done 25 years ago, there's a nice... Sorry, guys. Sorry. Someone is calling me and making a mess here. So if we compare it, there is a way of comparing those things. But I think now the technology for telesurgery is ready to use. Is kind of plug and play. Of course, it's still difficult, but it's completely different from the 25 years ago. It's much easier because those guys, they were obliged to get things upside down to make this happen. Today, you have very good connections. Today, you have very good equipment, different from the technology 25 years ago. For example, the Edge platform has the second generation of telesurgery molding, and it's becoming easier and easier. And we are talking about now more than 2,000 telesurgeries already done, of course, in different distances. So I'm not meaning that everything is going to change in the next year. We're going to have hubs of telesurgery all over. But I think, and I believe that in like 5 years, we're going to have it. Just one comment from Dr. Michel that I think it's important. Today, we're facing, of course, an explosion of AI and etc. And the robots, they will be able to perform our surgeries. They have already started them with success. But I think that the connection between surgeons will still be needed in the future. So everybody here used to travel to work, travel to operate patients abroad. So with this kind of technology, I'm pretty sure that this will make our lives easier, especially for the patient, guys, because in Brazil, it's very common that patients need to to travel big distances in Brazil to have at least a decent surgical care.
Marcelo, one question from Claudio, and then Ana, and then we continue. Claudio Maciel asked you regarding the responsibility of the preoperative evaluation and postoperative follow-up, and his question is, in your view, what are the key elements needed to guarantee safety and overall success in these patients that you are going to operate in this distance? You're mute.
Can you repeat the question, please, a little bit?
Yes,
Sorry.
regarding the responsibility and in the preoperative evaluation and postoperative follow-up, and how are you gonna guarantee the safety and the overall success in this kind of telesurgeries?
Okay, regarding the responsibility, there is a initial understanding that this should be more where the patient is than where the surgeon is, the surgeon connected, the surgeon abroad is. So, but this is a question that must be further developed, of course, and I think we're going to have a difficult time to overcome this barrier. But this is a long question. This is a long discussion.
Yeah.
Regarding the safety, we must do telesurgery with redundancy. That means we must not rely only in cables, for example. This is one way of telecommunication, the fiber optic cables. We can do also, and we must have at least today a 5 or 6G working, because if the cable for any reason does not work, we have a redundancy. We must have a team that is able to finish the surgery, the local team that is finish the surgery. So if you think so, the next question is, so why are we working with another team if the local team is able to finish the surgery? This is in the beginning. This is for safety protocol. Once we are more used to have a platform that is reliable, telecommunication that is reliable, everything is working properly, I think we're going to move for a less restricted rules. So today, these are the standards. You have to have a local team that is able to finish.
I think we have some problems with Marcelo's connection. Anna, meanwhile, you can do your question.
We must
Marcelo,
have a redundancy of
we have some problem with your communication. We need three, Marcelo. We need three. We have three more questions and comments, but very, very quickly. Question and a very short answer.
Okay.
Anna.
Okay, my question is regarding the reality of robotic surgery in LATAM. Which one do you think will be the biggest barrier compared to other regions? Would be simulation and start training and level up the surgeons in LATAM, and afterwards work with the robot acquisition and the telecommunications, level up in different countries, because it's not the same along all LATAM. So which one do you think will be the first barrier to overcome, and the role of simulation and telementoring for level up the skills and knowledge of the surgeons in LATAM?
Yeah. So the first thing is that simulation is essential. If you want to train a robotic surgeon, he has to pass at least for a 20 hours or 30 hours simulation. So this is one point. Of course, the certification of the robotic surgeon must pass from other levels. So training is essential, as essential step to have it spread in the continent. This is one thing, training. And I deeply believe that training must be done, especially in training centers, just like ours. That's why we have put the robot inside a training center. What is different from the normal way of thinking? Because can you imagine, in terms of revenues, what is a robot in the training center? Completely different from a hospital. So we were very courageous to spend so much money to put up a robot in a training center. And I deeply believe that this is the way. We have to train people. We have to train there then in a porcine model, for example. And this only can be done in training centers. This is one thing. The other thing, Anna, that is so important is the CapEx, is the amount of money that you have to invest in the beginning. And for sure, this is the challenge for us. We are like a, let's say, poorer country, so we have to put money on that. I can tell you that in Brazil, now they understand that this is the moment to develop the robotic surgery. Brazil has more or less 200 platforms. There are places, there are cities in the United States that has more than the entire country. Of course, we are very far behind, but we have to look forward and try to make our best. And I think robotic surgery is here to stay. So, and all over the country, people are convinced of that too.
Marcelo, Kike Arias, one very short question and most short answer, and then we'll continue with Michelle. The last one, please.
Perfect. Marcelo, congratulations. I think that is an amazing topic. What do you think we are missing to perform, for example, a revisional bariatric telesurgery from Brazil to Central America? What is the next step?
To perform a telesurgery, you need the same kind of robot. So the brand must be the same. This is one thing that I think we should change. Those telephones, those smartphones, they should connect between each other. So this is one policy that we are beginning to address. So we have to have the same platform, for example, that we have. So if Dr. Palermo wants to operate from Brazil in Escola, in our training center, a patient in Central America, this must be the same robot. We have the Edge robot. You should have the Edge robot. The Edge robot has a telesurgery molding. So you have to have telesurgery molding too. Once you have both, you must have also a connection between us. That in general would be a fiber optic connection. We have a lot of fiber optic connections across the countries. 25 years ago, there was so few. But today, if you take a look at the world map of fiber optic connections, there are lots of them. Only in Brazil, we have more than 40,000 kilometers of very, very high performance fiber optic cables. So we must have connection in the same robot. And sorry to delay your presentation, Dr. Michel, but it's your fault. Because if it wasn't for you, we wouldn't be here discussing telesurgery.
So, Marcelo, thank you very much for your great presentation. And we move to Michelle. Michelle is going to talk us about magnetic anastomosis, and we continue innovating. Michelle, the audience is all yours.
Well, thank you very much. Thank you, Mariano, for this invitation to participate in your IFSO LAC webinar. The last question of answer of Marcelo, when I was at the Cleveland Clinic, I had the first Zeus robot in 1996. And when I moved from the Cleveland Clinic to Mount Sinai in 1998, we brought this Zeus robot to Mount Sinai. And I was collaborating with Maresco with his new center, IRCAD Center, and he wanted to buy a Da Vinci. And I said, if you buy a Da Vinci, we won't be able to connect and make this transatlantic. So I had to convince Maresco first to buy another Zeus robot or get another Zeus robot so we can talk to each other. So you're right, you have to have the same system. So closing this, let me share my screen. Hopefully you can you see this? Because I can't tell if you are seeing this. Can you see this?
Yes, perfect.
Okay, thank you. So I was asked to talk about MACD more specifically. And my disclosures is that I am a stock owner of a company that makes a linear magnet, and I have written a book on the overall larger topic of magnetic surgery. Right now, we have 3 magnets that are FDA approved, the 32 millimeter, the 4 centimeter, and the 5 centimeter. We're not using the 32 millimeter, and I will expose to you the reasons for this. As you know, rare earth is the supermagnet comes from neodymium centrally. It is a alloy of iron, neodymium, and boron. And you need to know this because it's toxic to the body. It's a temporary implant, and it has to be encased in titanium in order to protect from toxicity. Magnetic anastomosis is nothing new. We did not invent this, and the Russians were among the first to use the magnet in canine model in 1978, and in humans it was used in the Netherlands, 29 adult for colon anastomosis. A lot of the development has been done in Moscow, the Filatov Children's Hospital, And from 1978 until the collapse of the USSR, there was a lot of publication, PhD dissertations on the use of a magnet for urinary and gastrointestinal colorectal anastomosis. These were the pioneer from Isakov, Stepanov, Geraskin, and Vasilev. So we're talking today about linear magnets. This is one shape. It's a bit like an endo-GIA versus a circular one, which would be an EEA stapling technology. The advantage of the linear magnet is you can increase the length to make a longer anastomosis. It's transported in front of the endoscope, and the anastomosis is done delayed. It's a delayed anastomosis technology to avoid cutting the mucosa and getting bleeding or leaks, and preferably making the anastomosis several weeks later. There is a central necrosis between the magnets, and the anastomosis is not between the magnets, it's around the magnet. It's important to understand the difference. We have to have instruments to the magnet themselves. You need a pair, you need catheters to deliver, you need a laparoscopic positioner device for this procedure to transport the magnet at the appropriate place, and you also need ancillary instruments and non-magnetic instruments. The magnet itself is encased in titanium, the central core magnet, to make it non-toxic, and there's a flange made of polyglycolic acid that dissolves, and that's where the anastomosis happens and is being pinched. After 14 days, this falls apart, and then the necrosis is finished, and the magnet passed through and get expelled by defecation. The closer they get, in the first days, water gets expelled between the two magnets. They get really close at 3 days. They never touch each other because there's a platform of cells that without water, it's a kind of a little leather that stays in between. And obviously, you want to enlarge the anastomosis, you have to elongate the magnets. Here's the magnet next to the PillCam and the Duracell batteries. Now, in order to get a larger anastomosis with a circular magnet, you would have to get a real big circle, and this may pose a problem in the passage in the GI tract. This is the array of magnets, 32 to 80 millimeter, depending on the site of the anastomosis. Most used right now is the 40 and 50. You need to have a single magnet because it aligns itself always perfectly. If you have an array of magnets, it can pose problems in the getting adequate attractions. The generation 1 and generation 2 magnets, the 32 millimeter was a completely titanium. The surrounding was titanium, and it kept pinching the tissue too long as opposed to the biofragmentable flange. These are the catheter delivery system that attach to the magnet for delivery, and the laparoscopic positioner device to surf the magnet inside the abdomen are from 12 Newton to close to 27 Newton. So there are 5 different forces, but right now they have to go through a 12 millimeter trocar. And we have endoscopic magnetic retrieval device that goes into an endoscope so that you can get a magnet out if it is left in the stomach, the duodenum, or the colon to retrieve. We have made titanium liver retractors. There are some instruments that are non-magnetic and intestinal bulldog clamp for clamping the intestine if you do delivery of the ligaments of Treitz. I obtained some patents 17 years ago on full endoscopic compression anastomosis using magnets. Here's a picture at the duodeноileal anastomosis. And a company was formed 5.5 years ago with 2 engineers in order to produce these magnets. This is the first prototype. As you can see, it's not like that. And we did first, the delivery system was attached above the magnet and found out to be not the right position, and now it is exactly in the center of the magnet. We did, again, porcelain model test. This is an example of macroscopy with very little, if not none, adhesions between the duodenum and the ileum, as compared to the enterotomy closed with the suture that had a lot of scar tissue. Endoscopically was really great, good alignments. And why are we doing endoscopic magnet compression anastomosis? This is a study done by UCSF, Dr. Harrison in California, in the intestine of the primate using circular magnets. They had to have a higher burst pressure than staples. The same findings was from the Russians using the intestine of the rabbit compared to hand sewn. You can see that the purple was magnetic compression and anastomosis requiring a higher burst pressure at any time of the anastomosis versus hand sewn. And finally, this Chinese study on gastrointestinal anastomosis shows that it takes 3 times less time to do a magnetic compression and anastomosis, that the Nair score, which is the scar tissue outside, is twice as less than control, and granulation tissue is also dramatically less in magnetic anastomosis than control. So we introduced the duodenal anastomosis 17, 18 years ago for a duodenal bipartition called magnetic duodenal or MAGD versus a CD, which is end to side. And the side to side permits absorption of minerals in the duodenum and access to the biliary tree. It's reversible with single stapling and therefore has some advantages. But the price is probably less effect on weight loss and comorbidity. We can also do the procedure for type 2 diabetes without any stomach operation. So as I've explained, there's decreased absorption of calories and fat and stimulation of incretins. It's reversible with laparoscopic linear stapling, and it can be revised to a SADI to increase the weight loss. It can be revised to a complete duodenal switch if you want. After the necrosis, the passage of the magnet is in the distal small bowel. It never goes to the proximal small bowel and gets expelled by defecation. And you can see the sewing. We close all mesenteric defect on the left side to prevent internal herniation between the mesentery of the transverse colon and the mesentery of the ileum. Now, for those who are interested in this technique, there are 5 ways to deliver the lower magnet. You can use a short pediatric colonoscope and send this to the trites and have an upper gastroscopy for the duodenal delivery. You can swallow in the morning, surf in the ileum by laparoscopy, and do an upper duodenoscopy. You can do a direct ileal enterotomy and upper duodenoscopy. You can do a direct ileal enterotomy and an upper swallowing. You can do double swallowing without endoscopy if it's done correctly at the right time. Both magnets will be in the system without the need for endoscopy. It's an assisted procedure, and therefore we need a laparoscopy to measure the intestine correctly, to make sure that no tissue gets interposed between the magnets and close mesenteric defects. So the magnet is transported in front of a regular endoscope. There's nothing special. There's not double lumen, it's single lumen. And you can, if you deliver this to the trites, you want to do your first case in the morning, you can clamp the jejunum and deliver it there and take it from there to send it to the site at 250 centimeters from the ileum. A second endoscopy will get the upper magnet in the duodenum, and then you can dock them, and they will create this bipartition over several weeks. We started in November 2021 in Georgia, Tbilisi, the first 5 patients with Dr. Abuladze, And this was published. You can see each of the 5 patients and the 100% placement with 80% excess weight loss at 1 year and a drop of hemoglobin A1c of 2 points, and as well glucose of drop by close to 48 milligram per deciliter, with very few complications, most grade 1 and 2, the Clavier-Dinto classification. So the swallowable magnet now of 4, 5, and 6 centimeter have all been able to patients to swallow all of them without any problem. This is an example of the patient that comes in the morning and is given early morning because you have to calculate 2 hours of X-ray. And then the magnet is given and swallowed with the water, and then we give also a mineral oil, 1 glass, and 2 hours later, you can see it's present in the X-ray. It has to be below the iliac crest, and if it's on the left side, it's in the jejunum. If it's on the right side, it's in the ileum. We then get into the operating room. We will split the greater omentum. That's make sure there's no adhesion in the duodenum, splitting the greater omentum. After that, we measure the intestine and put a clip on the mesentery at 250 centimeter. We then look for the magnet from trites to down where the magnet is, and then we can surf this magnet from the jejunal position to the ileal position. I'm here rotating the intestine, making sure that all the proximal jejunum is rotated towards the left side. This is surfing with contratraction going from proximal to distal. And the serosal tear does not happen with the laparoscopic positioner magnet, but from the ball forceps. So you need to have a ball forceps that is not, that is atraumatic and doesn't have any sharp edges. So when the endoscopy is done in the duodenum, you will dock distal to the light of the endoscope, and that's post-pyloric, and you can micro-position this by pushing the duodenal magnet, the ileal magnet towards distally in order to get a distance of 1 to 2 centimeters from the pylorus and being not through the and here, you can have a screen to see the endoscopy. The endoscopist will show you the proximal end of the magnet, and if it's touching the pylorus, you need to surf it or push it more distally. Then the disclosure of the mesenteric defect. This is done with non-absorbable sutures. Anything you like, from silk, proline, barbed wire, wires, Etibon, etc. And then you have to recheck your bowel where you did the surfing, making sure that there's no serosal tear, because as you see in the results we will show you, there's 2 patients that require suturing. So let me tell you about some of the latest result. This is if we look at some of the patients from Australia, Canada, Chile, Georgia, Italy, and Mexico, some of the patients that were in the trials. That's 143 patients. And some had 32, 40, or 50 millimeter. You can see the majority had 40 millimeter, 90 patients, and 29 had 50 millimeter. The body mass index is listed there. There's slight difference between the 32 millimeter had higher BMI, and percentage of female and male is expressed there. The average age is pretty much the same, between around 44 and 45.5 years. There was past 100% for 32 millimeter, 97% for 40 millimeter, and 50 millimeter was 93. And that some of the patient required to have endoscopy to remove a magnet that was sitting in the colon. Here you can see two magnet retrieval, by colonoscopy. So the hospitalization time, you can see median was 1.0 day, mean 1.2 days. The passage of the magnet that we knew was in the toilet was between 30 days to 36 days. That doesn't mean that it's the time that the anastomosis form. We know it's less than that. In terms of adverse events, there were 2% of adverse events related to the magnet. There was a duodenitis or inflammation in the duodenum that we thought this might be the cause of the magnet sitting there too long. It was a 32 millimeter, and we're not using this anymore. Failure to expel with no clinical symptoms, and a small ulcer at the mouth of the anastomosis. There was one event that had a bowel obstruction with severe adhesion band in the pelvis from a patient who had a previous hysterectomy. This caused a severe bowel obstruction that required reoperation. There were 2 cases of iatrogenic perforation. And so one was due to the endoscope, when the anastomosis was too small in 32 millimeter, endoscopists went and dilate these anastomosis, and that created a perforation. There was 2 duodenal ileostomy reversal, one for malnutrition and another one for elevation of liver enzymes at 5 months. The other one, malnutrition, was at 9 months. So you can reverse, that's 1.4%, because of problems of the surgery. In terms of weight loss, between the 32, 40, and 50 millimeter, you can see it's 16% total body weight loss at 1 year with the 50 millimeter. If you translate this to percentage of excess weight loss, it's 66% excess weight loss with the 50 millimeter, and between 30 to 40% with the 40 millimeter. And obviously, 32 millimeter was not weight loss enough. There's an effect on hemoglobin A1C, and the strongest one is the 50 millimeter, where it drops at 5.1. So in terms of anti-diabetic effect, the bigger anastomosis, and the glucose as well. C-peptide, because this is a representation of less insulin production. In terms of patient satisfaction at 1 year, with the 40 millimeter, 88% would redo this and send a family member or a friend. 12% were dissatisfied because obviously the weight loss was not as much as with the 50 millimeter, where at 50 millimeter, there was 100% satisfaction with the procedure. So this summarized the MAGD. I think we went through that with the data. I think 67%, close to 70% excess weight loss with the 50 is pretty awesome when we compare to other types of surgeries like gastric bypass. Now, in terms of type 2 diabetes, this was the most downloaded paper of the year, last year, in the Journal of the American College of Surgeons. I was surprised to find this out. And this was for type 2 diabetes alone without gastrectomy. It was a series done in Georgia and 15 patients. 100% diabetes. Body mass index was 33, so in stage 1 obesity. And the average body mass index, as you can see, is 33. The hemoglobin A1C was 8.2. And the operative time was 51 minutes. The hospital stay was 1 day. Expulsion time was 24 days, and 100% placement. We had modest weight loss because this was not the intention, but still we had 43 to 40% excess weight loss. And hemoglobin A1C went from 8.2 to 6.5, and the glucose from 188 to 131 at 6 months. So this is a 40 millimeter study. We're doing one with 50 millimeter linear magnets, and you can see how potent the 50 was. We expect better result than what this is already good results from the study. I'm going to finish this talk with some new concept. We are working on magnetic distalization of the Roux-en-Y gastric bypass. This is a magnetic jejunal-ileal connection. It's similar to the jejunal-ileal bypass we did in Prague with Martin Fried with a 5 centimeter magnet. The patient comes in the morning. This is for weight regain after Roux-en-Y gastric bypass. We give them they swallow the first magnet. We then go at laparoscopy. We serve this magnet to the distal ileum. The second magnet is introduced by gastroscopy while the patient is asleep. Those two magnets are connected, and we close the mesenteric defect. And 3 weeks later, the magnet pass, and you have a distalization of your Roux-en-Y gastric bypass. If you want to know more about this, I will present in 12 days the whole procedure and the rationale of this new procedure called the magnetic jejunal ileostomy for revision of gastric bypass. And of course, we have our big, sorry for the advertisement, our big international symposium on full day of live surgery, June 26, and talk on June 27, an event not to be missed in Montreal at the same time as the Jazz Festival. Thank you very much.
Thank you so much, Michel. A great talk as always. We have 3 questions from the audience, and then we go for the question and comments from the expert and panelists. One from the audience. We should use an overtube to insert the magnet by endoscopy?
No.
Okay.
My first patient, I did, and it was a mistake because we had mucosal tear from the esophagus from the overtube. So I said, get this out of there. And we never needed an overtube since then. So over 599 procedures.
Okay, one more from Monica Vera. The BMI of the patient has something to do, and the abdominal wall thickness in the coupling of the magnets, or no?
Yeah. Like any anastomosis, the first principle is avoid tension. So you have to do maneuvers to avoid tension. One of them was, first of all, when you're going to start to do this procedure, patient selection is important for you to learn this procedure. You would not start a Roux-en-Y gastric bypass as your first patient in a male patient with BMI 60. It's difficult. So these patients are more difficult for everything, including magnetic surgery. The duodenum is very high, and you need to get the ileum to go there. So we split the greater omentum on the right side. This releases some of the tension going over the transverse colon. Adhesions down the pelvis. A lot of female had pelvic surgery, and the ileum is stuck on the right side. You need to take down those adhesions, and you can mobilize the cecum to rotate the ileum to go upward. And this is a maneuver to release the tension. If there is still a bit of tension, you can put stay sutures on each side to avoid having the magnets, coming close to the surface.
Great. One last question from the audience, John Carrasco Flores. Why we should do anastomosis with magnetos if we can do it with magnets, if we can do it with staplers?
Yeah, I presented to you 3 studies that demonstrated that the anastomosis was stronger with compression versus sutures or staples. So you want to improve your results, you want to improve the care of your patients, you want to improve the safety of surgery. Magnets is going to be the way to go in the future, in my opinion. This is the first time we're starting to do this. So we're only going to get better over time. And it's going to be an instrument that is going to be in your toolbox. It doesn't prevent the use of sutures or staples. You're going to have sutures, staples, and magnets. And then you're going to decide which patient is best for each clinical situation.
Perfect. Nathan, then Camilo, and then Varas. Nathan, you start.
Thank you very much for coming and for a nice presentation. The question I've been hearing from people, I love the magnet anastomosis. I don't have any doubts this is going to be the future and the present. When you do the regular anastomosis, you hands-on, that is going to cost you $40. Then you do the staplers plus the staplers that maybe is going to cost you, I don't know, $900. And then you do some staplers, some suture that is going to cost you $600. Do you think the price of the magnet will prevent people to use it? Should we do something about the price of the magnet for the future? Because I will love everybody to use it, but especially in Latin America.
No, it's a good question, Nathan, and it's the same question for robots. You have a robot that costs $2 million, $2.5 million. As more and more companies get there, more and more production of the same product, it's a capitalist question: is how much production you're going to make, the price is going to come down. And I think that at the beginning of any new technology, the price appears very high, but I think it's going to come down. Also, it's not just the cost of the anastomosis, it's the cost of the causes of the anastomosis. If you have strictures, if you have bleeding, if you have leaks, the cost of that, as you know, is very, very expensive. So when you come to convince the administrators of this new technology, well, it's expensive. What's going to be the benefit? Well, if the patient can go home 2 hours after the procedure, you don't have to keep the patient in the hospital because you're not worried about bleeding and leaks. It changes the overall total cost of the procedure. That's how it has to be sold.
Camilo.
Hello, Michel. Very nice
Hello.
presentation.
Yeah.
Yes, you hear me? Yeah. We have performed probably around 40 cases, and it's technology, the anastomosis is really, really, really nice. My concern is that I thought that honestly the 5 centimeter was going to achieve a bigger anastomosis. That seems very reasonable, but now I've been seeing that even in 4 centimeters, sometimes the anastomosis is big. Do you think there's other factors that affect the size of the anastomosis?
Yeah, the tension.
Rather than just the distance,
Yeah.
or
I think the tension is
Okay.
an extra factor that we did not calculate at the beginning, and I think that I am advocating people to put retention sutures, one on each side, to just release a little bit the tension, because it appears that the tension may pull the ileal loop down and may result in a smaller anastomosis. So if you have had no tension at all, you may see a large anastomosis with the 4 than with a 5 that is under a lot of tension.
Yeah. And do you think that there's something else rather? Because honestly, the sutures on the 5 centimeter, we are not able to put those sutures, especially in the duodenum. Or maybe
I don't agree with that. I think you can put a stitch between the pylorus and the ileum.
Okay, but not saying that do something different, doing a Kocher maneuver or something different rather than putting sutures. That was my question.
Well, you can do a Kocher maneuver, but the upper duodenum is fixed with the bile duct and the pancreas, and there's so much you can do for mobilization. So the upper part is only so much you can do. But the lower part, you can mobilize the cecum and actually create a bascule, that is a rotation of the cecum ileum going upward. That you can do.
Julián, and then Edgardo. Thank you, Camilo.
Oh, thank you, Michel, for your presentation. I was very lucky to see the procedure live at your clinic in Montreal.
Okay.
So I've seen a long way now that you've expanded this worldwide, and congratulations for that. So beyond type 2 diabetes, have you observed any emerging patterns in surgeons' preference or patient selection, for instance, in cases of weight regain or inadequate response after sleeve gastrectomy? And also from a technology point of view, can you give us a little window to the future of how you're modifying the
I've been lately spending a lot of time on doing the gastroileal anastomosis, magnetic side to side, and it appears to be easier to do than the duodenal because the antrum, the mid stomach, is lower and there's less tension at that anastomosis. The endoscopy is super easy because you only need to pop in the stomach and the magnet is right there, and everything, these procedures can take 20 minutes. So, and the patients can leave the same day. It's extraordinary. So the gastroenterostomy magnetic is also giving similar result, if not any better, than the largest anastomosis in the duodenal. We use a 60 millimeter magnet in the stomach. This magnet stomach is probably going to be used by every surgical oncologist on this planet for palliation in pancreatic cancer. So I think that's going to be the door of entry for each hospital to have magnetic technology. And then maybe the bariatric, the metabolic are going to start to use the tools for their own patients. But it's going to be interesting to see if in our randomized control trial comparing magnetic surgery and GLP-1, which one is going to win? Because, let's talk about this among ourselves. What is killing the numbers of bariatric surgery is the efficacy of GLP-1, and they have a lot of new drugs coming. It's going to dramatically drop the number of bariatric surgery, and we need these tools like this to get back with safety, quick recovery, very minimal surgery, and I think we need these tools.
Edgardo?
Thank you, Mariano. Thank you for the invitation. Michelle, we had together with Mariano and Michelle in a MACD procedure at the end of the last year, and it was amazing. Congratulations for your talk, and of course, Marcelo too was amazing in the talk. I have a question for you, Michelle. Do you think that the magnetic compression anastomosis will replace, in some indications, to staplers?
Yeah, I think in colorectal, it's going to be a revolution because in both ends of the GI tract is where you have the highest leak rate, the rectum and the esophagus. There is going to dramatically change the picture. And surgeons may use only the magnets in these instances in order to decrease the leak rate. Now, I think still the stapler are needed to do a gastrectomy, to do colectomies and to remove things. So you still need staplers. You will still use sutures, depending on the type of surgery. And as I said, magnets are going to be preferentially used in certain procedures. Inflammatory bowel disease. We don't know how they react in peritonitis. Maybe in peritonitis, the magnet do better than staples and suture. So we need to do a lot of things right now. We're only at the beginning of this field.
For example, in Wilkins syndrome, there is automesenteric compression of the duodenum could be the...
Yes, in supramesenteric artery syndrome, I've done 5 patients in which the magnet is in the third duodenum and the other magnet is in the proximal jejunum. We put them together. These are malnourished patients. They have problems of wound healing. And by putting the 2 magnets without any enterotomy, you can send them back, and in 3 weeks, the anastomosis happen. It's a total game changer.
Yeah,
of course.
Totally agree. Michelle, one question from Shaq Invents. What are the advantages of magnet compression over mechanical compression by nitinol?
Well, I think by there was the Niti company. There was the Israeli company that created the compression device that was used as an EEA, and they also had a device that was side to side, and they failed to make the market. I don't know, 20 years ago or something like that. Unfortunately, the problem is it's not swallowable. It's not transportable, easy in the lumen. They were made for open surgeries. So that was a problem. But nitinol is an interesting concept because it's a metal that changes conformation according to room temperature versus body temperature. And if you use this correctly, you could compress at body temperature. There's compression. We use the elastics, for example, to compress over, and you can create the same thing. I use the Valtrac. The Valtrac was used in the 80s as a compression device, and the Murphy button and the other French button were used at the end of the 19th century, beginning of 20th century. So whatever compression device you have method works, but I think the magnet here, the beauty was that we get consistent compression with the force of a single magnet, always the same force, and it's swallowable and transportable.
Great. Quique Arias.
One small question, Professor Gagné. Do you think that we will find the way to move the magnet inside the small bowel without surgery at the future?
Yes. Yes, I think with magnetic field, sort of like a big MRI machine, a patient goes in and with the computer, you're going to be able to move with artificial intelligence. As I said, you need to find a way to get the proper measurement of the intestine. You're going to be able to move them away. So that's a very interesting futurist concept. We've been able to use the magnet recently, and I will do a webinar on the reversal of gastric bypass. This is going to be a more and more interesting concept where you use two magnets to reverse your gastric bypass instead of getting into a difficult dissection and situation.
Great.
But I think completely endoscopically is probably the next step, and after that, using machines with magnetic fields.
Great. Another question or comment, Marcelo, Ana?
Which one do you think is the biggest contraindication to perform this surgery in a patient? Which one patient we should say no to magnetic anastomosis?
Well, obviously, if someone needs an MRI within the time where the anastomosis is going to be formed, that's an absolute contraindication. Pacemakers is another one. A stricture in the GI tract that would prevent expulsion is another one. Sometimes it's previous bowel surgery, lots of adhesions, partial bowel obstruction, things like that. Pregnancy is another one at the moment.
One other question, is possible to assess how many of the food is going through the
Yes.
illegal?
Yes, in fact, Dr. Guy Bernard Cadier from Brussels has done this study using technetium-99, a bit like a gastric emptying study with technetium-99 meals in nuclear medicine. And you can assess how much of the radioactivity goes in the new connection as opposed to the old pathway. With a 3-centimeter magnet, it was only 20% of the flow was going through the new connection. And the weight loss result was a deception for us, at best 20% excess weight loss. While with a gastroileostomy, they estimated that the flow was between 80 to 90%. So when the flow goes into the ileum at 80 or 90%, you get super weight loss. So it's somewhere in between, probably the best results. That's why the 50 millimeter magnet and the 60 millimeter magnet in the stomach are probably giving results of the 50-60% flow, but they need to be repeated with the same technology with different sizes of flow of anastomosis.
Michelle?
Marcelo, and then Camilo.
Oh, it's a completely different technology that he's presenting to us. It's not a crazy thing that was took 25 years to go back and to retry. This is something ready to use, and we all see the potentials for it. It's an amazing technology. Again, thank you.
Coming to Brazil soon.
And
Michelle,
come to Skull, huh?
Hello?
Michelle, for revisions, you think that you're going to stay at the end, you're going to advocate the gastroileal for revisions rather than the duodenoileal at the end of the day, or what do you
At the
think
end
is
of the
going to
day,
happen?
it's easier to be performed. I think we have to see a bit longer term results to see if there's ulceration as a result of the gastroileostomy. This is my concern. We tell the surgeons to keep patients on proton pump inhibitors to avoid this, but there's a risk of ulceration in the gastroileostomy. There's more dumping syndromes. They might be getting more malnutrition over time. So we're going to need probably 3 to 5 years follow-up to know about the more long-term problems of a gastroileostomy versus a duodenal. Now, in a gastroileostomy, we go at least 3 meters. So it's a longer small bowel in order to not get in trouble from what I just said.
Perfect.
Camilo, you are mute.
To advance the 6 centimeters now, it's getting difficult, or it hasn't been an issue, or you open just
60
the
millimeter,
bowel?
the patients have all been able to swallow. We use a trick of a gastroenterologist. We freeze with xylocaine the whole mouth and throat. We put the 60, in fact, they swallow it without even noticing it. So this is a trick for difficult patients as well for smaller size magnets.
Michelle, last question from Daniel Rojas. He congratulates you for the presentation and asks about how do you handle the bile reflux after MACD?
MACD, we haven't seen a lot of bile reflux, tell you the truth. I'm more concerned with the MAGI, the magnetic gastroileostomy with bile reflux. So I think it's going to be the same as a mini gastric bypass in terms of bile reflux. So because we've done only about 50 cases of gastroileostomy, so I don't know. I don't think it's enough to answer the question of how many are having bile reflux at the moment.
Great. Okay, I think we are on time. I would like to thank again Marcelo Loureiro for your great talk about telesurgery, and Michelle about the MACD, and Nathan, Julian, Ana, Quique, Camilo, and Sergio, and Edgardo. And we wait for you in Cartagena in March from 3 to 6 in our LATAM Congress. Thank you so much.
Thank you. Bye-bye.
Thank you. Bye-bye.